Welcome to Going Antiviral, the podcast for the IAS-USA, a professional continuing medical education organization focused on HIV and other viral diseases. I'm Dr. Michael Sagg, professor of medicine and infectious diseases at the University of Alabama at Birmingham and volunteer member of the IAS-USA Board of Directors. In this episode of Going Antiviral, we represent a panel discussion as part of the dialogue series Latest Updates on Urgent Virus Outbreaks that's sponsored by the IAS-USA. This update was presented on June 11, 2024, and the panel was moderated by Dr. Paul Volberding from UCSF. The panelists included Dr. Yvonne Maldonado from Stanford University, Dr. Carlos del Rio from Emory University, and Dr. Peter Chin Hong from UCSF, all who are expert in viral diseases, their epidemiology, and their treatment. And with that, let's begin.
Hello, everybody. I'm Paul Volberding from UCSF, and as always, really happy to have this very informal discussion. This is organized by the International Antiviral Society USA. Lots of credit to the organization and the staff that do this. The intention of these discussions, for those that haven't been here before, is to talk about especially viral issues that we're facing. When we started these discussions, it was really all about COVID. I think we've, in a sense, put that on the side, although we'll hear that two of our panel members have COVID right now, so it's not gone. But we've added other things because people are obviously very concerned about other viruses, avian flu and maybe RSV, maybe MPOX, and some of those things that we'll try to talk about today. As we go through the dialogue, we encourage participation with the audience. You can ask questions. I think Q&A is the best Zoom way to do that, and we'll try to watch for the questions as we go forward. We have our family with us today. Three discussants who I'm tempted to say don't need an introduction, but maybe some of you haven't been with us before. I'm just going to look at my screen and mention them by name, and then I'll ask them to say good morning as well. Peter Chin Hong from UCSF, Carlos del Rio from Emory University, and Yvonne Maldonado from just on the highway here at Stanford. Take it away. Peter, do you want to introduce yourself? And not 15 minutes, but maybe just 5 seconds.
Hi, everyone. I'm Peter Chin Hong. I'm the professor of medicine in infectious disease, transplant ID at UCSF. I'm the associate dean for regional campuses.
Great. Carlos.
So Carlos del Rio, I'm a professor of medicine and infectious disease here at Emory University, and my work is primarily around HIV, but with COVID, everybody has shifted to COVID and now pathogenic influenza. And
do you want to tell us about your infection today?
So I came back from Lebanon 2 days ago and started feeling sick yesterday, having a sort of scratchy throat and runny nose, and tested myself for COVID, for influenza, and that was all negative. But I spent the night coughing a fair amount, and this morning I tested myself again, and it's COVID. And I've heard about several people who have returned. I travel via Europe. I've returned several people that have returned from Europe also with COVID. So it's just a reminder that COVID is not gone. This is my second rodeo with COVID. I had it back in 2022, and this is much less severe. I don't feel as sick, and it's just like having a bad cold, basically.
All right. If you have to cough, just mute yourself, Carlos. Bonnie, good morning. How are you?
Hi, good. I'm Yvonne Maldonado, and I'm professor of global health and infectious diseases at Stanford School of Medicine. Glad to be here.
Super. So why don't, and Bonnie, you're also just recently COVID positive, is that right?
Yeah, I was at a national meeting or an international meeting in Toronto, and with a cast of thousands, and got sick.
Yep.
I'm better now.
I think the message might be because I think it was my second bout of COVID, this is now a couple of years ago, was also obviously connected to a plane flight. I'm not sure that the CDC is telling us we should consider masking on planes. I see almost nobody doing it, but some do. And I think probably in my own experience and from what you've heard from Bonnie and Carlos, maybe if you got those masks still stuck in your back closet, you might want to put them in your suitcase so the next time you fly, you might be able to keep this from happening. I think, as Carlos has said, many people find the second or third episodes to be quite mild. But as we can talk about later in the program, that doesn't mean that it's insignificant or that you might not give it to somebody who really experiences much more serious disease, or that it might be linked to personal experience with long COVID. So try not to get any of these things that we're going to be talking about today. So why don't we then continue talking about COVID? Bonnie, you've been involved in a study of long COVID with Paxlovid, the treatment. Do you want to tell us about that and what results you saw?
Yeah, so this was done by my adult infectious disease colleagues here at Stanford. It was a subset of the original Recover study sites, and this was a single site study looking at essentially 3x times the dose of Paxlovid, so 15 days instead of 5 days. And it was a 2-to-1 placebo-controlled trial. Interestingly enough, the placebo included ritonavir because of the taste issue. They wanted to make sure they didn't know they were on placebo by not tasting anything. And the bottom line is a little under 160 patients enrolled in the study, and there was no difference at 15 days out. 15 days of therapy, there was no difference 10 weeks out with any of the symptoms. And notably, the symptoms were categorized into 6 different buckets of long COVID type symptoms, and there was no significant difference in any of those 6 groups in the 2 groups. So essentially a safe treatment, but not effective in reducing long COVID.
So disappointing, I think, for those of us that hope that might be a positive trial. And the ritonavir unblinding is an interesting one, having taken Paxlovid myself and become sympathetic to my HIV patients for whom I prescribed ritonavir a long time ago, of course. And the taste is obviously an issue. Carlos, you mentioned your international traveling, and for those that don't know, Carlos is very involved in global health issues. And do you want to give us a perspective, Carlos, on what you hear from colleagues in other countries about COVID and whether our experience today is any different than theirs?
Well, I think it's a little different in the sense that, the U.S. made a commitment to just one strategy, right, which is the mRNA vaccines, and we can talk about the new vaccines that are coming, but we're not using any of the other vaccines. Even though we had the Novavax vaccine tested, it really never made it the way it should. So we really have one strategy. Other countries have multiple strategies, but vaccination still continues to be an issue. In many countries, they don't have vaccines. In many countries, they don't have access to antivirals. Paxlovid, as Bonnie said, didn't do much in long COVID. And there's even, myself and others question whether it makes even sense to prescribe Paxlovid today in people who get COVID, because you really don't see much of a difference. It doesn't decrease infectivity. Somebody's asking in the chat whether it decreases transmission. It doesn't decrease infectivity. It doesn't decrease the viral load. So I think we need better antivirals. I think we need better approaches. We have a monoclonal antibody that Peter can tell us more about later that has been approved. But as the virus evolves, I think there's a big need to really continue doing research on COVID to develop better vaccines. We're chasing the virus as it mutates. By the time the new vaccine is going to come out, it's no longer going to be really targeting the virus that is circulating at that point in time. And we need better research into antivirals. So my biggest concern is that the NIH has really cut the COVID research pipeline. They only have their Recover study, the long COVID study, but all other COVID research has stopped. And I'm very concerned about that.
So
So let me just mention
go
something,
ahead,
Paul, really
Bonnie.
quickly
Yep.
around that. I'm sorry, I meant to mention it earlier. One of the things that we noticed at the very beginning of the pandemic when we were enrolling patients in all of our antiviral studies is that people they didn't feel great, but they didn't feel terrible within a couple days after they noticed they were infected. But we started noticing that, as we all know now, that people got really sick maybe 3 to 5 days or more after the onset of symptoms. And by then it was really too late to enroll them in some of these trials. And one of the things I noticed just on with my own patients and myself, I monitored with my infection, is my oxygen saturation level is actually not normal, and I didn't feel it. So we sometimes underestimate how potentially hypoxemic we are initially. And so I worry about if we are going to be treating some of the people who are at higher risk. Obviously, my SO2 went back up and I was fine, but it was down in the low 90s, which is not normal. And I
Yep.
have my asthma, but nothing, I didn't feel sick. So I worry that we're not focusing on maybe those high-risk individuals who perhaps need to take something earlier on. And we just haven't done a great job, I think, of looking at that population. It's really hard to do now because people aren't
Yep.
testing.
That might be a good time to put a plug in for people to get their own O2 sat devices. They're totally available, very cheap, and reliable, I think. So I think, as Bonnie said, if you have symptoms, it's not a bad idea to check and see if you're sicker than you really think you might be. Peter, let's talk a little bit about what you're seeing. I know that your specialty includes immunocompromised hosts, especially hospitalized patients with transplant and other things. All through the pandemic, we heard that people, some groups of people were at especially high risk for COVID. What did you see with the COVID pandemic and in your really very compromised patients? And what are you seeing now? Are you still seeing concern about that?
Yeah, so during the pandemic, we saw quite a few immune compromised patients hospitalized in the ICU. And they weren't, I think there's a lot of confusion in what immune compromised means. But, to me, in the world of COVID and in terms of vaccine response, a poor vaccine response is people who've been on, B cell depleting agents or recent stem cell transplant or solid organ transplant or graft versus host disease. But so those are the people who tended to do poorly. But the interesting thing is, I was in the hospital for the last 2 months, probably 3 or 4 weeks, and I'm still seeing a few immune compromised patients who are hospitalized and sick with COVID. And like 100% of them, because I was interested in this, didn't receive the last booster that was XBB 1.5 released in the fall of 2023. And when you look at the CDC data, I think they say only about 18% of immune compromised patients have received the new booster. So I think, again, it really speaks to the fact that some patients are still in the hospital, even though the vast majority of us are not, if you get COVID, and that to really attenuate risk, you really should encourage folks to get that new booster.
Let's stop there for a second, Peter, and Barney and Carlos as well, and talk about the current status of COVID vaccines. I personally get a little bit confused because they've come out with a certain regularity now, and it seems to me that recommendations about who, when should be vaccinated have changed. Peter, why don't you start? I know Bonnie's very involved in the vaccine coordination effort, but Peter, why don't you start and just tell us right now what should people be thinking about in terms of COVID vaccine? Then we can add as we talk more about flu and other things. So, Peter, do you want to get us started?
Yeah, so I think the new vaccine guidelines are meant to be simple. Either you got it or you didn't get it, like the flu shot. Rather than keeping track of how many boosters and it became kind of crazy for a while. So my question to people is, did you get the new shot unveiled in the fall of 2023, yes or no? And that's really the question. And of course, we know that the CDC has also authorized an additional shot if people over 65 want to get it, at least if the last one was more than 4 months ago.
Let me just say,
folks, yeah,
that would be another shot of the one that you may have gotten last fall.
Yeah,
right?
XBB
Okay.
1.5.
Yep. Okay.
And immune compromised patients can actually discuss with their clinicians about getting one every 2 months if they want to. Nobody does that, but that's an option for people.
Great. Thanks. And go ahead, Carlos.
The FDA, Paul, just recently approved a new COVID vaccine, and this is a vaccine that is targeting the JN.1 variant. And the JN.1 variant back in March was the predominant variant, but it has really, by now, it's really gone away. And that's what I was saying, that the most recent data from the CDC suggests that it's only about maybe 3% of the variants in circulation, and other variants are emerging. So, we keep on chasing variants, and the virus keeps on moving faster than we can. So again, emphasizing the point that this is not about chasing variants. This really has to be about developing new strategies, because the reality is, there's really not a lot of benefit if you're chasing variants like this. And there's a study published in Lancet Infectious Disease recently from Denmark showing that really the updated vaccine last fall at a population level really didn't do much of a difference, because it really benefited just a very, very small number of individuals. So I go again with what Peter said. If I'm thinking about giving an updated vaccine to my patients, I'm thinking about those over the age of 65, 70. I'm thinking about immunocompromised individuals, but I don't think it's something that the general population should take, quite frankly.
Well,
so, Bonnie,
if we think back to the original idea around, I absolutely agree. But let's go back and not we don't want to damn the vaccine, right? So we're not where we were in 2020 when nobody had immunity. So we are actually where we are kind of supposed to be with this virus. I don't think this is really out of line with what we thought coronaviruses do. They mutate. Immunity doesn't last very long. But at the same time, in 2020, nobody had immunity, and we saw millions of people die. But now we have population immunity from vaccines and infection, or a combination of both. And so the vaccine is not going to be as effective in the general population. And I think this is exactly where we have to think about evolution. One of the questions is this going to become a seasonal organism? It really doesn't look like it's settled on a season yet. So, and we know that in 2025, there will probably be a COVID flu combo vaccine, which might be helpful. It might give the extra protection or extra herd immunity, but for sure, it'll bring those flu vaccinees along with it. So I think we're evolving with the virus.
I have another question about this. That I wonder if you had somebody who was absolutely not herd immune, somebody who hadn't been vaccinated, had never been previously infected, is there something different about the current variants that's circulating compared to the original ones, to Omicron, for example? We saw a lot of people get really sick. We saw a lot of people die. And yet the current cases that we're seeing tend to be very mild. Is it a different virus, or is it have mostly to do with the host immunity? Anyone want to jump on that?
I think it has to do, I think first of all, we don't know for sure, but I suspect that we were seeing, I think about HIV, right? You have the tip of the iceberg was AIDS, and I think similarly, we're seeing the tip of the iceberg were people with underlying conditions, elderly individuals, et cetera, who were really more likely to get very sick. I mentioned to you that I measured my own oxygen level. It was not great, but I didn't go to the doctor. I didn't go to the hospital. Nothing happened to me. We don't know that there's the denominator, the vast number of people who got infected. We knew we're not going to die or even be hospitalized, but given that the transmissibility was so great and the fact that there was no susceptibility, in the population in 2020 compared to now. And the fact that there's about a 1% mortality rate, we could just crunch the numbers. I think we would probably still see that a completely susceptible person, depends on how old they are. If they're 15 to 17 years old, they're probably going to be fine. If they're 65 to 75 and they're healthy, otherwise they're probably going to be fine too. So I don't think the virus, I mean, obviously the virus is mutated, but it's not worse. It's probably much more transmissible than the original virus was. But in terms of virulence, I mean, I'll hear what Peter and Carlos have to say, but I don't think there's evidence that they're more virulent now, with or without immunity, underlying immunity.
So probably a lot to do again with the herd immunity, with the fact that so many people have now fortunately been vaccinated.
Yeah.
I'm not going to ask.
Yeah, when you said Paul, you said, I have somebody who's never had COVID and who hasn't been vaccinated. I said that person must have just arrived from Mars or something like that, because
yeah.
I don't know that that individual actually exists, right?
Well, I mean, fortunately, we've had some experience now, and it seems to be attenuating us. I'm not going to ask anyone to comment on Dr. Fauci's latest appearance before Congress. I think we all share some of the same concern about how he was treated. But let's shift a second and talk about long COVID. It's been a little bit in the news. I was involved in a committee that came out with some thoughts about disability issues with long COVID. Another report is coming out just today on the exact definition of long COVID. What are we seeing? I mean, I know that it gets back to my question about the original variant, that it turns out obviously that long COVID was more common than early pandemic. Thoughts about this? What are you seeing, and what should people be thinking about? Bonnie, I know that there's been a program at Stanford.
Yeah, well, we haven't, and again, Peter and Carlos, please weigh in as well. First of all, we think that between 5 and 10% of the population will have evidence of long COVID. And even in the more recent study we did here at Stanford with a small number of patients enrolled, it got better over time, but these were people who had long COVID symptoms for at least 3 months. And I think the average was somewhere like 8 to 10 months. So they were already kind of long-termers, and the numbers didn't go down to zero, but they looked like they were starting to trend towards more mild symptoms over time, even among the placebo group. So I would say that, as you know well, Paul, we're trying to put a better pin on what does long COVID mean. It's really a kind of a garbage can diagnosis, if you will. There's very different manifestations, and there may be different pathogenic reasons for that. So I don't think we really have good evidence yet from Recover around what we're dealing with, other than how to treat some of these symptoms, not actually cure them or prevent them. But we're still in the same boat that Carlos mentioned earlier, where we don't have any good ideas yet on how to prevent or treat the overall long COVID spectrum.
Great.
In terms of incidence of long COVID, there is some data, like a study in JID, showing that it's going down over time, but that more recent data suggests that it kind of stalled currently around, like what Bonnie said, around 7.5%, but then most people get better within 12 months. So
let's shift. We can always come back to COVID, and I'll try to watch the chat as well. But another virus that's been really in the news now has been the avian flu. Where are we? What is this virus? We've heard about it for a long time. Why are we hearing about it now? Carlos, do you want to start talking about avian flu?
Well, we've been concerned about avian flu all the time, right? It's something that worries everybody. Viruses, birds are the natural reservoir for this virus. They travel. The current virus that we're seeing, the H5N1, was first seen in Hong Kong, and then it traveled to Europe, and then wild birds brought it to the Americas. And we've had it here affecting birds. It has caused millions of chickens to be killed, turkeys. It has traveled to South America, where it also impacted marine mammals, seals, sea lions, with thousands dying as a result of the infection. This virus now has infected the cow herds, And I think that's really what's very different and interesting, that cows were not seen as a normal host for this virus in the past, but now we're seeing it there. And I don't think we fully understand how cows are getting infected and what's happening with the herds. What happens to the cows is most of them don't die, but they get depressed. They stop producing milk, and as a result, we've seen there's now been a total of 3 cases, 1 in Texas, 2 in Michigan, of people who work in the farm industry who now have gotten infected. One of them had respiratory symptoms, the other 2 had only conjunctivitis, and they all done well and they all have recovered. So there's still a lot for us to understand. Again, it's an emphasis that we need to have a One Health approach. It's an emphasis that we need to have CDC and USDA and other agencies working together. I think there's been, we're seeing the backlash from COVID. My discussions from people at different levels is that the farmers are very concerned. They don't want to let people go in to test their employees. They don't want to do anything. They want to pretend that it doesn't exist. They're worried about their business. They're worried about losing a profit. And again, I'm worried that we're not doing what we need to do precisely because, the lack of trust in public health. And I'm very concerned about that because to me, our biggest Achilles heel is the lack of trust in public health.
Well, so the other issue, though, when you think about this, there have been about almost 890 cases of highly pathogenic avian influenza in the world so far in humans, and with a mortality rate. Now, remember, these are symptomatic diagnosed cases. The mortality rate is 52%. So we're talking about a pretty serious infection when someone actually gets sick. We've been very fortunate with these particular cases. I think from a prevention standpoint, Carlos brings up an amazing point, because if you think about it, people, if they test their animals and they're positive, they can't sell them on the global market. So Europe won't take them. It's hard to sell them in the US as well. So it is an existential problem for these farmers. At the same time, the reason we don't see vaccines, there is a vaccine available for animals, chickens and cows. And of course, there's stockpiles for humans that we've had for over 15 years now. The problem is if you vaccinate an animal, there's 2 things. One is the animal may be asymptomatic and still be shedding. So you can't go back and test every chicken and cow before you vaccinate. So the question is, how much will a vaccine help there? Can they actually then still transmit if they're vaccinated? And then the last thing is, if you are vaccinated, you have antibody, and that's how you screen. So is it natural disease or is it vaccine? I think we should just wipe the slate clean and do these studies now in animals, because we're going to face a situation where we're going to really be wondering, should we just start vaccinating? And right now it's not, USDA has said it's not cost effective, but we need to understand, I mean, like we did with COVID, how can we build those models of testing using all those assumptions? Let's assume that an animal is asymptomatic and can still spread. Is it still worth building herd immunity? Build a different test that measures a different, a different antibody, a different antigen or epitope that isn't in the vaccine, so you can detect natural infection in cows or birds. I think we're being very short-sighted because this is really a high mortality pathogen.
I feel a dad joke coming on when you mentioned herd immunity in the setting of cows, but
I was just thinking that too. It's the original.
I saw you smiling as well, Peter. Great. We'll try to get serious.
Yeah, but I think Paul, I just don't want to miss this opportunity to say that there's some interesting studies happening about infection of unpasteurized milk, and in fact, several cats died for drinking unpasteurized milk. And I just want to emphasize, hopefully our viewers and our people listening to this are not drinking unpasteurized milk. There's plenty of reasons not to do it, including brucella, but yet now we have a new reason not to do it, and that's highly pathogenic avian influenza. So please, it's not healthy. Don't drink unpasteurized milk.
So,
eggs and beef are safe, as you know it.
So Peter, while you got the microphone, I know Bonnie wants to talk too, but you've mentioned, I think, also the issue of the death from another variant of avian flu, not the one we've been talking about. Do you want to talk a little bit about that?
Yeah, it was just a case of H5N2 in Mexico. We don't know too much about this case, but the patient apparently had other multiple comorbidities, and maybe Carlos or Bonnie, you might know more about it, but it was not. I mean, a lot of people ask me, was this like H5N1 that mutated, became H5N2, but it's not. It's like a completely different family. Like H1N1 is different from H5N1. So it's not like an evolution of the virus. And that's kind of all we know, but it does speak to the high mortality rate of some of these, highly pathogenic avian influenza strains getting into human populations. And to me, that's what it really signified.
So I'm curious, what do we know about the symptomatic presentation of H5N1? Is anything that clinicians might be watching for? Is it a typical influenza? Is there anything special? Anyone want to tackle that?
Well, I think we're seeing this farm workers present with conjunctivitis, and we don't know that's because of their exposure, how they're getting exposed, etc. But they can
I've heard speculation it might be from milk spraying.
Yeah, like aerosolization could be what's happening, right? But it could also be that they're touching the milking equipment and then touching their faces. We really don't know. There's also if I was working in the industry, I would be using PPE right now, honestly, and I think it would be very important to wear goggles and to wear gloves and to do good hygiene, because we can certainly prevent this from happening. But the most typical symptoms are obviously respiratory symptoms, GI symptoms. We see a fair amount of them in this cases. The person that died in Mexico presented respiratory failure. And yes, it was somebody who had underlying conditions. But again, he died of this virus, right? And this H5N2, and it's probably related to poultry in that case. So obviously a concern.
When you look at the global cases outside the US, the ones that have happened over the decades, they've been in a variety of populations, not just immunocompromised, all ages, mostly not children, but young adults, older adults, some with immunocompromised, some not, but presenting with respiratory symptoms and then respiratory failure.
I mean, the one sort of like relative silver lining right now is that you may know, but the CDC recently did these studies on ferrets, which are apparently a good model for human flu transmission. So they took the strain of one of the patients in Michigan and infected 3 ferrets and then put 3 uninfected ferrets next to them, and they all got it. But when they took one of the ferrets who got it and tried to infect other ferrets through respiratory routes, it wasn't quite efficient. So, but the point is, like, maybe this one right now isn't as isn't efficient in terms of respiratory spread, but it may evolve with mutations very easily.
So, thank you. So, another virus that we should talk about, given that it's Pride Month, is a virus that's been seen, at least in this country, heavily affecting the gay community. Someone want to start us talking about where we stand with MPOX and what should people be thinking about, especially as they might be going to large events?
Yeah, Peter, why don't you take that one on?
Yeah, so many people we all remember that in 2022, there's a global outbreak of Clade 2 MPOX, which isn't as bad as Clade 1, there's a outbreak right now in the Congo. And Clade 2 spread to, I think, 117 countries, more than 97,000 cases, quite a few deaths, particularly in HIV-infected individuals in the US. So the question was, would it just go away, or would it kind of stay at a baseline low rate? And the sort of jury is now saying that it's at a low baseline rate, which means that they are susceptible people, as new people come on board with risk, unvaccinated, they're going to be susceptible because there's this baseline rate. There was an MMWR last week talking about the baseline rate in emergency departments around the country. We know that New York and Chicago had a little spike recently, 91 cases in New York in the last 6 months and 69 in Chicago in the last 6 months. Bay Area, San Francisco, only 9, but the point is that with prior activities, just like in 2022, when you have people moving around, you can spread risk. And many people didn't get the second shot. And we know that the second shot can give you anywhere from 66 to 89% efficacy, as opposed to in the 30s to 70s for the first shot. We have a lot of it. We have kind of forgotten about MPOX. So I think that's the reason for reminding our patients to go ahead and get at least one shot, if not the second shot, right now.
And how long between shots do you have to wait? I mean, is there?
28
it has
days.
to be, yeah.
So Paul, I want to emphasize, we have a vaccine. It works fairly well. Get the 2 vaccines. If you're at risk, you should be fully vaccinated. You're going to be fine. The study that CDC did is, if you only have 1 vaccine, you're still going to get disease. It may not be as severe, but you're still going to get infected. But again, the other important thing is we saw a really high morbidity and mortality from MPOX in our country, primarily among African Americans, primarily among people with HIV who are not in care, who are not virally suppressed. It really is a reminder that we got to vaccinate those persons, but we also have to get them back into care. We have to really get them viral load suppressed, because the biggest risk of dying and having very severe MPOX is HIV-induced immune suppression that has not been controlled with antiretroviral therapy. Again, reminding us of the importance of, we have the tools to keep people healthy from their HIV. We're just not using them appropriately. And I really think that's a huge failure of our public health system and of our care system, quite frankly.
Well, I'm tempted, Carlos, to start screaming out loud, because I think the point that, so many of these issues come down to public health and how fragmented our system, if you want to call it a system, has become. Maybe we'll make that a focus of exclusive dialogue so we can solve the problems of public health in the country. But it's a real issue.
Yeah,
Fine,
and if we think about the global setting too, if you look at the clade 1, which is more transmissible and severe, we're seeing about 20,000 cases right now in the DR Congo, and there's no real effort. I mean, the vaccines are just not available in that part of the world, which is, we're fortunate here in the US and Western Europe where we haven't seen clade 1 yet, and hopefully we won't. But we could also, the efforts in the global setting to vaccinate and to provide diagnostics and treatment need to be remembered as well.
So are the vaccines?
I would say that not tackling and not approaching appropriately the clade 1 outbreak occurring in the DRC is really a huge failure of global public health. We should be doing much more, and there's a lot of opportunity to deploy vaccines, to deploy antivirals, to deploy science and learn about the disease. There's so many things that could be happening.
Carlos, does the vaccine that we have for MPOX here work in clade 1? Is it a separate vaccine?
The feeling is that it's going to work against clade 1 as well. It's close enough, and we don't have any clinical data, but the immunological data suggests that it's going to be neutralizing against clade 1 as well.
So that's good news, I think, because we obviously now have a pretty good supply of the vaccine available.
Correct.
But yeah, good. So
not only that, too, just a reminder, we could multiply times 5 the current vaccine if we need to deploy it elsewhere because of the route of administration.
So I guess it comes down to making sure people are as aware as possible that the vaccines are available. And I would guess that these are mostly through local public health departments. Where do people get the MPOX vaccines?
Yeah, through their public health departments are really, and actually CDC had pulled together a working group to really get the public health community, where there was a task force at the White House as well. And I think with all the other issues that have come around and the sense that this is really dropping off, which just hasn't really been deployed lately, but public health agencies should have access to the vaccine.
So I'm looking at the chat, and I'm very sorry. One of our participants had a close family member who had long COVID and who quite a long episode of it and died probably as a result of complications of that with pneumonia. So a reminder that these are serious challenges that we still see. We talked, I think, at the last of these dialogues about another virus that's been around a long time, measles. And we'd heard that there were problems, especially I think in Europe, with measles outbreaks. Anyone want to, Bonnie? Do you want to talk about measles?
Yeah,
And where we
measles is
are?
it's our perennial problem, and we, obviously we think about it in kids, but it's a pretty, and that's probably because once you get vaccinated or infected, you have lifelong immunity. It's one of the few vaccines that provide sterilizing immunity. But actually, last year we had almost double the number of cases as the year before. Now, you might think that that might be related to better reporting, but I think there were just some major outbreaks, mostly in Eastern Europe and some parts of Western Europe. But for example, in 2022, there were 171,000 cases. Last year, there were 320,000 global cases. This year so far, we're at 94,000. So it may be peaking out, but we're still seeing a large number of cases. In the US, we've had 151 cases so far this year. Last year, we had 58 all year long. And it was this year we had 21 states and New York City. Our worst year in the US was in 2019. We were seeing a lot of hesitancy around vaccines. There was a lot of efforts to really pull that number back down, and we did well. But during the pandemic, a lot of people didn't get vaccinated. And with the high R naught, measles is highly contagious. R naught is 12 to 15 or so. We're at risk for more outbreaks. So we're worried about the global population. As you saw, the numbers are pretty high. The death rate is highest among little kids. So, and most older adults probably already have natural or vaccine-induced immunity. So really is a concern for children at this point.
And for those of us that are old enough, the immunity is really lifelong. Is that right?
Yeah. If you become immunocompromised, the possibility you lose immunity. But actually, even with HIV infected individuals, what we've seen is if you're reconstituted, you actually can develop pretty good immunity from the vaccine. So it's really, again, to Carlos's point around making sure people are controlled and get up-to-date vaccinations, because you can lose your immunity if you're immunocompromised.
Just as an aside, but it is interesting, isn't it, that with some viral infections, immunity is very strong and durable, lifelong, and others that we've heard about even on the call today, immunity is not very good and doesn't last very long at all. So I think a lot of work still to do with understanding the nature of immunity and how we can better manipulate that.
But I think worth emphasizing, Paul, that we have a very, very effective vaccine against measles. I mean, the cases we're seeing is because people are not getting vaccinated.
Yep.
And I think, if you get your kids vaccinated and they get the 2 doses of measles vaccine, they're not going to get measles. They're going to be protected. They're not going to get measles and its complications, including progressive multifocal leukoencephalopathy. There are many, many problems with complications from measles and long. So we need to really remind people that this is a disease for which we have a good vaccine. And to see cases again, it's very depressing because we have an effective vaccine. We have an effective tools.
I think one of the scariest
things
for me is that the vaccination at entering kindergarten is going down over time. So that's dipping below 95%, which is what we kind of need for herd immunity in measles. So it means that people who have waning immunity or immune compromised people, they'll be suddenly vulnerable if this continues.
And because measles is so highly transmissible, to get herd immunity, you need to get about 96% of the population vaccinated. So 90% doesn't get you there. You really, really need to get very high levels of coverage.
I think, Carlos, you mentioned PML at some point.
No, it's actually not PML. It's actually progressive sclerosing, encephalitis.
SSPE.
Yeah, but I thought about PML because somebody had a question there.
I was going to ask you, That's what prompted my question, Carlos.
It's interesting you bring up SSPE because we actually did have case reports here from California. There were over a dozen cases of SSPE reported in California over a period of several years. It's a really rare phenomena that occurs. it's a long-term horrible degenerative disease that occurs in people who have been infected with measles at a young age. And there is a treatment, but it's really mainly only to keep someone alive. It really, these people suffered tremendous neurologic damage. And we did see clusters of those over the last 10 years or so. We haven't seen any new cases recently, to my knowledge, but it is a concern.
And Bonnie, SSP is always a little confusing to me. Like 7 years later after you got the measles, you get this thing. Is it like a long?
Well, so yeah, so it is. So what Diane Griffin at Hopkins was really the one who demonstrated that what happens is when you get this infection, there are incomplete measles viral particles in the brain. She actually was able to document that. So you have incomplete immunity when you're not vaccinated, and you develop this smoldering subclinical replication of the virus in the brain, and then eventually it just takes over, and you wind up with weird psychiatric and developmental manifestation. The average is 1 year, but it can be as long as 5-7 years after measles infection. Very hard to document that. We've had a case here at Stanford, a child who went abroad under a year of age, so technically wasn't eligible for measles vaccine, got some kind of rash-like illness. Nobody ever documented what it was. And then 2 years later was diagnosed with SSPE.
So it's a different condition I recognize, but one of the chat members asks about progressive multifocal leukoencephalopathy, PML, and JCV, having seen something on a Twitter or X stream. Anyone want to talk about this? Is this something that the audience today wants to know about? Don't all jump at once.
Well, PML is one of the opportunistic infections we saw in people who had very advanced HIV, but now we're seeing it also with some of the monoclonal antibodies. Natalizumab is one of them that actually has been associated with PML. And so, it's the setting of severe immune suppression that you can get this virus emerge. Natalizumab is a drug that has been used for multiple sclerosis, and one of the risks is getting PML when you use this drug for multiple sclerosis. So it is something that we're probably going to be seeing more as we have more immunosuppressed populations, because at the end of the day, it's severe immunosuppression that puts you at risk of this infection. And we need more research into PML to really understand it and understand how to treat it, because at this point in time we really don't, and there's so much work that needs to be done to understand. And I think the field of neuro infectious disease, to me, is prime for a lot of research to happen.
Yeah. So I'm going to shift another dramatic shift in direction to another real case here among our panel members. Recently, one of us had a regular old viral URI, turned into this really bad chronic bronchitis that lasted a couple weeks. And one of us went into the urgent care clinic and was told that every other person they're seeing has this condition of a post-viral bronchitis. Anyone want to talk about that? What do we know? And is this something new, or is this something we've always seen and just kind of worrying more about viruses? Bonnie, you want to?
Yeah, there are at least, it depends on where you are, but, we can now diagnose, 10 or 20 different respiratory viruses. And certainly we know pertussis is actually one of the most common causes of, if anybody is diagnosed with a cough that lasts more than 2 weeks, the vast majority of those people are going to have pertussis. It's just that in adults, we don't get cyanotic and intubated because we have big airways, so we do okay with it, but it's highly likely to be propagated in families. We know the vaccines are terrible. Even the best ones don't do a great job. So pertussis, parapertussis, adenovirus, parainfluenza, there's a whole host of viruses that can actually leave you with a post-tussive, post-infectious coughing, chronic cough. And so maybe it doesn't last more than 2 or 3 weeks, but it's still pretty distressing when you have it for that long.
So, Bonnie, I know that you're very involved in the vaccine efforts. One of the things that we wanted to talk about today, at least in brief, is travel vaccines. Any message that the people attending today should think about travel vaccines?
Yeah, so yeah, I think everyone I know is heading off somewhere fun this summer. But I really think what you should do, the best thing to do is go to the CDC travel guide, cdc.gov, and then just try travel medicine. They have really up-to-date maps. They can tell you what to take, but generally you have to be up to date on your immunizations, measles that we talked about. Again, most adults probably don't need to worry about that, but kids should be up to date. There is the polio is something we talk about. There's only 2 endemic countries now, and we're actually down to like single-digit cases. Well, no, we have now 12 cases, but still, we're getting very close to eradication. But still, there are areas where we have to be concerned. So if you're an adult, you're in near some of the Middle Eastern areas where there's still endemic disease as the sub-Saharan belt, you might want to think about a dose of injectable or IPV. Hepatitis A, typhoid fever vaccine for important areas. Cholera is still around in parts of sub-Saharan Africa and other parts of the world. You might want to think about that. Malaria, of course. And I think yellow fever, if you're going to places where there is yellow fever, those are the big ones. But again, if you go to the CDC website, they really will actually tell you that even if the province you're going to has some of these diseases. So I would look at that and make sure you go with enough time, because some of these, so for example, with some of the vaccines, you need to go in for 2 doses. And some of them are oral vaccines. You can take them at home. They're not long lasting. So if you got one 10 years ago when you took your family somewhere, it's not, cholera, typhoid, yellow fever, none of those are lifelong. So you need to probably come back and get one again.
The bottom line is look at the CDC site. Carlos?
Yeah.
So one of the things that I'm worried about in travelers right now is people going to India and other places, Southeast Asia, is dengue. There's a lot of dengue, and we need to remind people, that for dengue, what we have right now is primarily, wearing long sleeves, insect repellents, avoiding being outside at sundusk. But we have to remind people, I've seen a couple patients with returning travelers with dengue, and it's something that we really need to remind people. There's, at this point in time, well, we have some vaccines, they're still not routinely used in travelers.
Yeah, I wouldn't
And
recommend.
with
Well,
climate change,
yeah.
all of this
Yeah.
is changing too rapidly. So
And we're seeing a lot of dengue in South America too right now. There's just outbreaks all over. So yeah, I agree.
And I think a large number in Florida as well. Is that right? Yeah. I'm going to go to the chat. When I look at chat, I'm always tempted to look at the participant list and see my friends. The only person I'm going to shout out today is Merv Silverman. Merv is a frequent participant in our dialogues and a good friend and the health director in the San Francisco with the start of the AIDS epidemic. It's dangerous to talk about people on the list because there's so many people that are good. But one of the questions that's come up is again a question of immunity. I'm not going to say herd immunity, but it's herd immunity to COVID. In Sweden, Sweden had a very different strategy as a response to the pandemic. Does someone want to talk, maybe Carlos, about what the experience in Sweden has been, and whether there's a lesson for other countries? You're muted.
I think Sweden had a different approach to COVID in the sense that they did not force strict lockdowns, and they relied more on voluntary and sustainable mitigation. They clearly have a population that I think it's probably a lot more responsible and a lot more dedicated to understanding what needs to be done. And there's better housing. There's there's not as much crowding as we see in many of our cities. There's not a lot of the disparities. There's the countries in the northern countries have really invested in social determinants of health, and that makes a very different approach. But however, the data on excess all-cause mortality indicates that that they did have a lower mortality early in the pandemic compared to other countries, but then after that, their mortality that did go up. So it's hard to know exactly what their approach was, but I mean, I think the most important and the results. I think the most important lesson is we need to invest in social determinants of health. When you provide a social safety net, when people have housing, when people have, the mortality we saw in our country was in large part a reflection of social, of social inequities and health inequities. And I think at the end of the day, we need to really emphasize that health equity is, when we think about herd immunity, to me, the way to provide herd immunity in these infections is called equity, right? And we need to, equity is the herd immunity that we need.
Well, and unfortunately, what happened with Sweden and other places is people use those experiences to say that normal public health practices didn't work. So they're saying, masks don't work, distancing doesn't work because, look, they didn't do anything in Sweden. It's not that they didn't do anything. They already had a very well integrated system that worked really well. If you, in theory, could isolate everyone 75 and older and not isolate the rest of the community in your big country, then in theory, you might be able to put a firewall between those at-risk people, but that just isn't possible in most parts of the world. So conflating those two places, Sweden and the rest of the world, is just doesn't make sense. And it doesn't mean that masks don't work, because that's the other, the counterfactual there is, right? So therefore, if we hadn't used masks, we would be fine. So that's not the case. Are you going to talk about RSV at all? Because I want to pitch for the vaccine.
Sure, go ahead. Make a pitch.
I just want everybody to remember that we have 2 and maybe 3 RSV vaccines out right now. There's a new Moderna RSV vaccine for adults that will be looked at by CDC this month, but I don't have any data yet really to suggest what happened. We did have a big RSV season this year, almost as big as the year before, but it flipped. Whereas in 2022, 2023, it was highly focused in children. It was really a horrible year with lots of kids on ventilators, et cetera. This year, it was almost as high, but it was primarily in people 65 and older. So we did still see, and I haven't seen the numbers yet on hospitalization, but it looks like the numbers were pretty high. It wasn't overwhelming, but certainly was a higher number. And we know that the vaccines in real world effectiveness studies have shown between 60 and 80% reduction in hospitalization. So hoping that people look at that. And I know there was concern about AFib with the vaccine. And so far, we'll see some updates on that data, but it hasn't really panned out that the vaccine was associated with AFib in older adults, at least not in the vaccine safety data link data so far.
Can I add a quick factor
about the
RSV vaccine too, which is that the FDA just approved the GSK vaccine for those over 50. So they've been like very immune compromised people, particularly those who have gotten lung transplants who are under 60. So I think that will probably broaden higher risk groups to get the RSV vaccine for this upcoming season.
And I want to thank everyone for participating and thank the panelists and thank the staff. It's been a really good discussion today again. Thank you all.
Thank you for listening to this episode of Going Antiviral. Catch up on earlier episodes wherever you listen to podcasts, and check out the video versions of this episode and others on the IAS-USA YouTube channel. You can find these links in the show notes, or simply go to YouTube and search for IAS-USA, and there they are. Be sure to subscribe, rate, and review Going Antiviral on Apple Podcasts. This podcast is for informational and educational purposes only and is not intended to serve as medical advice. Opinions expressed in this podcast do not necessarily reflect the opinions of the IAS-USA or its affiliates. If you have a question you'd like answered on the show, you can send it to podcast@iasusa.org to be answered in a future episode.